here.
So I'm so excited to introduce Lola Ogunyemi. She is someone that has been very patient with me over the years. I met her in 2009, and she really showed me the ropes of a lot of basics of informatics. She's the director of the Center for Biomedical Informatics at Charles Drew University, and she's also a co-chair in the UCLA CTSI's informatics program, and is also faculty in the UCLA radiology department. She got her PhD in computer science at Penn and was faculty in Harvard Medical School for a while before coming to Southern California. She's really one of the leading scientists in our field, and I'm very excited to hear what she's going to talk about today. In addition to this kind of work, she applies machine learning and imaging informatics to other kinds of clinical decision support scenarios, early detection, specializing in the healthcare safety net. So without further ado, I welcome Lola and looking forward to hearing her talk.
Thank you very much for that wonderful introduction, Danielle. It's a pleasure to be here. And as mentioned, I'll be talking about the methods that my center has used for tackling diabetic retinopathy using telehealth and machine learning. But to sort of give some context to the work I'm doing. So I'll say, so after I left Penn and went to, I worked as a research scientist at Brigham and Women's Hospital with an informatics group, and was there for about 7.5 years. And I'm originally from Nigeria. So in the back of my mind, I always thought I would return and teach there. And I wanted experiences that made sense for essentially a developing country. Charles Drew was looking for a director. Well, so obviously I never went back, but I thought I would. But Charles Drew was looking for someone to start a center for biomedical informatics focused on medically underserved populations and tackling the kinds of problems that I thought that I might also see there. And so I moved to LA, and a little bit of background on Charles Drew, because I know there's a lot of people that may not have heard of it. So it's a private, nonprofit, historically Black graduate institution, started out as a medical school only. And it's also dually designated as a Hispanic serving institution. We were rated by the Chronicle for Higher Education as, I think, the second most diverse university a couple of years ago. Our student population is about 34% African-American, 32% Latino, 20% Asian, and then the rest, all the other groups that you'd find in the US. And Charles Drew was established in 1966 in the aftermath of the Watts Rebellion in LA. And its mission is to graduate diverse health professional leaders who are interested in social justice and health equity for underserved populations. So in that context, the center was started in 2007, and I was the founding director to try to come up with biomedical informatics solutions for medically underserved communities. So our center is funded by a mix of NIH grants. We have a CDU NIH endowment for informatics, as well as state and foundation grants. And the faculty members in the center have backgrounds in computer science, internal medicine, sociology, and public health. So this, on the right, you see a picture of some of the medical students at CDU. So we've had a partnership with UCLA from the beginning. So our medical students start their first 2 years at UCLA, and then the last, so the pre-clerkship, and then the last 2 years they rotate through different safety net provider settings in South LA. So you probably are all familiar with the fact that Los Angeles is sort of divided into 8 service planning areas, and CDU is in SPA 6, which has 1.1 million people who are predominantly of Latino and African-American heritage, and unfortunately also has a disproportionately low number of hospitals, clinics, and medical specialists. So if we put that 1.1 million people, that number in context, that's more people than in the state of Delaware, South Dakota, North Dakota, Alaska, Vermont, and Wyoming. But the resources available to the people in that service planning area are nothing like you would find in those states. So 32.5% of SPA6 adults had difficulty accessing medical care versus 26.3% LA countywide. And SPA6 is a HRSA designated health professional shortage area. So that's one of the things that CDU is trying to address. So before I moved from Boston to LA, I didn't really understand what the US safety net meant. So, most of you probably already know this, so excuse my going over this if you already do, but this is something I had to learn myself. So the healthcare safety net in the US includes federally qualified health centers and FQHC lookalikes, as well as state and county hospitals that provide healthcare to about 16 million people across the entire US and roughly 2 million in the state of California, regardless of their health insurance status or ability to pay. So these are mostly uninsured and underinsured patients. And when I first moved to Charles Drew, the dean of the College of Medicine at the time who helped to recruit me was an ophthalmologist. And one of my colleagues was the medical director of an FQHC, THE, to help everyone clinic in South LA. And so he's an internal medicine doc, and he had a patient who had diabetes. And the thing with the federally qualified health centers at that time is that they were mostly primary care clinics. That is not a lot of specialty care happening. And so if somebody had a condition that required specialty care and they would have to be referred from the primary care clinic to either the Los Angeles County Department of Health Services, somewhere within that system where a specialist could see them. So my colleague had a diabetic patient come to see him, and he was really concerned because the patient's blood glucose was really high. He wasn't eating well. He was in pretty bad shape, wasn't taking his meds. And so he was concerned about some of the potential consequences from diabetes, including potential vision loss. And he referred the patient to the County of Los Angeles to see an ophthalmologist. And on the county's end, so the county is completely independent of the FQHCs. So these are different systems. The county, gets a lot of referrals from their own ambulatory care centers, as well as from FQHCs across Los Angeles. So we're talking about 2007, 2008. And the patient was referred and put on a waiting list behind like about 1,000 people, other people who needed to be seen. And he waited for a few months and essentially went blind while waiting to be seen by a provider. And that was essentially my introduction. It was like, okay, what can we do about this situation? That was my introduction to some of the problems that occur with the safety net. And so it had never occurred to me that essentially everybody did the right thing, but the patient fell through the cracks and lost their vision. And so at the time, I was aware of work being done internationally on using telemedicine as a way to bridge the gap. And so we decided to look into that. And we applied for a supplement to a center grant to look at teleretinal screening as a way of addressing the issue of diabetic retinopathy in safety net settings. So I'll give a little bit of an overview and a background of what diabetic retinopathy is, what the pre-telemedicine screening process was. I've pretty much given you an idea. The goals of our initial study, methods, results, and a discussion, and this will lead to the current work that we're doing on machine learning in the safety net for diabetic retinopathy detection. So diabetic retinopathy, if you're not familiar, is essentially damage to the blood vessels of the retina that's caused by excess blood glucose. It's something that's treatable, but if left untreated, can lead to blindness. Treatment includes laser photocoagulation therapy. And in fact, if a patient is able to manage their care and get their blood sugar levels back to sort of pre-diabetic, to the pre-diabetic stage, it's reversible, but most of the physicians I've spoken to have not met patients who are able to to make that, to reverse their diabetic retinopathy. It's the leading cause of blindness in working age adults in the US, and goes from essentially no disease to, in stages, from mild non-proliferative diabetic retinopathy. So a patient with mild retinopathy would need to be seen once a year. The ADA, American Diabetes Association, and other guidelines would recommend a yearly screening, just the same for a person who has diabetes who doesn't have any disease. And then it moves through moderate, non-proliferative, severe, and then to proliferative diabetic retinopathy, where there are these fragile blood vessels that grow and can bleed and burst. And that's one of the causes of blindness, is when those fragile blood vessels grow, proliferate essentially. And one of the things that laser photocoagulation therapy does is cauterize, essentially make sure that that can't happen. So there are known diabetic retinopathy risk factors in the biomedical literature. An obvious one is the length of time a patient has had diabetes. Others include, high blood glucose or poor blood glucose control, insulin treatment, especially for people with type 2 diabetes, high blood pressure, high cholesterol, diabetic kidney disease, obesity, ethnicity. African Americans and Latinos are considered as being at higher risk for diabetic retinopathy. And then smoking is a little more controversial. There's some studies that have shown that smoking has a negative impact on diabetic retinopathy, and others showing no connection at all. So on average, in the US in 2009, at the time that we got the supplement to start looking at this, about 60% of adults across the US who had diabetes received annual screening in accordance with ADA guidelines. But in the inner city safety net, that number percentage drops to less than 25%. And often when people think about underserved, they think rural underserved, because that, it makes sense to a lot of people. There's not as many providers, but we find that the same thing happens in urban areas where there are pockets where there's just no providers who set up or want to set up in a particular area. And so this is part of the problem. So some of the factors impacting this disparity in national versus inner city screening rates included a shortage of specialists for diabetic retinopathy screening, the large number of uninsured or underinsured patients in some of these settings. And then on the other side, patients' own misconceptions about the utility of regular eye exams. One of the unfortunate things about diabetic retinopathy is that for most patients who have it, they don't experience any symptoms until it's too late. So this goes over the process for retinopathy screening in South Los Angeles, before telemedicine, so pre-2010, and sort of covers what I mentioned in the initial story that motivated this project in the first place. So the diabetic patient is seen at a primary care clinic, usually an FQHC. They're referred to the county for an eye exam because that's considered specialty care. The county puts them on a waiting list, and 4 to 8 months after they're referred, they're screened. If they need care, they have to return for treatment. Otherwise, they're supposed to come back again in a year or so. So when we looked at teleretinal screening as a potential solution, we knew that digital non-mydriatic cameras had been used effectively for DR screening internationally, as well as in the US within the VA system. So the VA is really good at teleretinal screening for diabetic retinopathy because veterans are distributed all across the country in rural areas, as they have to have a way to provide them with quality care no matter where they are. And so one of the good things is that you can engage ophthalmologists or optometrists who are off-site. The problem of having specialists in a particular physical location goes away. You can engage, board certified ophthalmologists and other people who are off-site to take a look at an image of a retina and provide a diagnosis asynchronously. So our pilot study we got funds from the NIMHD to look at the barriers to and facilitators of using teleretinal screening to detect diabetic retinopathy in partnership with 6 South LA safety net clinics, so 6 FQHCs. And we wanted to know what proportion of images were readable. We wanted to know how acceptable teleretinal screening was to patients and to clinic staff. And we wanted to find out the proportion of diabetic patients at risk for retinopathy who received retinal screening in accordance with evidence-based guidelines and who needed treatment and received it. So we got IRB approval for the study from the CDU IRB and signed memoranda of understanding between the FQHCs and our center. We were able to purchase 3 digital non-mydriatic cameras for use in screening. So these are about $28,000 cameras at the time. And one of the reasons that the FQHCs were willing to partner with us is, 1, they were concerned about their patients. 2 is that, that kind of, expense is not something that they would routinely be able to make. And one of the things that the NIH had indicated is that after the study was done, they'd be able to keep the cameras and continue the screening work. So they were excited about that. You'll notice that we purchased just 3 cameras, so some of the clinics had to share a camera. So they would send their patients to a different location to get their eyes checked, to get the retinal images taken. We, on the grant, retained 3 board-certified ophthalmologists as readers for our program and arranged photographer training and certification with Jorge Cuadros, who's an optometrist and an informatician at UC Berkeley. And he's the creator of IPACS, which is software that's used for viewing retinal images and making, inputting information about whether the reader thinks that a person has mild, moderate, or severe retinopathy. So he flew down from Berkeley and helped us with training the photographers, as well as certification. So photographers had to meet a certain number of quality images on non-patients and be approved by the staff at Berkeley before they could start on actual patients. So we provided weekly monitoring of clinic sites and troubleshooting. And the most important thing from my perspective is that we arranged with the medical director of the closest county facility at the time to have patients with moderate or worse retinopathy seen within 3 weeks of our readers saying that they potentially had moderate or worse retinopathy. Otherwise, what we would have had is the same situation, except you would have people being referred to the county. Now they would know they had a potentially moderate or worse retinopathy, but they still wouldn't be able to get to the front of the line. So that arrangement where, okay, now there's actually knowledge of potential retinopathy in the patient, they get to move to the front of the line. For mild retinopathy, because the current guidelines just call for those patients to come back to be monitored every year. So they weren't candidates for being expedited. So in addition to the work that CDU was going to do, the clinics themselves identified staff medical assistants who would be trained on camera use. And these medical assistants were the photographers that took and uploaded retinal images into IPACS software, made referrals to county health facilities, and provided access to our study to medical records for abstraction. So image taken for the pilot happened between 2010 and 2011. And we later had retrospective data collection for machine learning. I'll talk about that a little bit more later, but we collected info on patient demographics, medical visit history, specialist referrals, and so on. So our board certified ophthalmologists readers used the IPACS software that I mentioned from Berkeley to assess the presence or absence of microaneurysms, retinal hemorrhages, cotton wool spots, and other indicators of retinopathy or progression of retinopathy to determine whether a patient had diabetic retinopathy or not, and the severity if it was present. Is it mild, is it moderate, is it severe, and so on, is it proliferative? They also graded the quality of the images taken by the medical assistants at each of the different facilities. And then in addition to that, we had a qualitative study. So one of the faculty members in my center is a sociologist, Dr. Sheba George. And she worked with Allison Fish, who was a postdoctoral fellow at the time, and with Erin Moran, who was a doctoral student at UC Irvine in anthropology, but also our project coordinator for the study. And so they conducted focus groups with 42 patients from the different FQHCs, 42 diabetic patients from the different FQHCs, as well as in-depth interviews with clinic staff, because we wanted to get at what both patient and provider concerns, attitudes were about telemedicine. So this is just what this is one of the cameras that we bought, and some of the study staff playing around with the camera. So in terms of initial results for the pilot, we were able to get 2,732 unique patients screened. You'll notice that the total number of screenings was 2,876. So some people had to come back again because the image quality was so bad that the readers couldn't make a determination of what was going on. The patient had to go back and get their retinal images taken again. So across the 6 clinics, we were able to screen 29% of the diabetic patients in that year. 1,035 were recommended for referral to a specialist. 48 had proliferative diabetic retinopathy, which is a stage at which those fragile blood vessels have grown and can burst and occlude vision at any time. 115 had severe, 247 had moderate, 246 had mild. I mean, they're referred, but to come back and be seen in a year. And one of the benefits of the teleretinal screening program was that other conditions, diabetic maculopathy, cataracts, other things could be detected from the retinal images, not just diabetic retinopathy. And so we had the most referrals were for actually things outside in terms of a single category. For 282 people referred for things other than some form of diabetic retinopathy. So we were interested in looking at barriers and facilitators of teleretinal screening. And one of the main barriers that we found was that many of the clinics lacked the resources. So the ideal, which we discussed, was that they would be able to integrate image taking into the primary care visit. So you go to see your provider about your diabetes and you get a picture of your retina taken right after. But because the photographers were medical assistants helping with different tasks, many of the clinics had figured out different ways to handle the fact that they couldn't afford to hire people just for camera duty. And so some clinics would have medical assistants available to take images several times a week from noon onwards. We had at least 2 clinics that designated one day. So they would have, like a Friday available for any diabetic patient to come in and get an image taken of their retina. And we found that didn't work as well. So the clinics that had multiple visits essentially did better than the clinics that had one visit, because if somebody came in to see their provider on a Monday, they were unlikely to come back again on a Friday. And the other thing was the learning curve. Those photographers who were only using the camera once a week had a steeper learning curve. They kept having to relearn things, versus those who were using the camera multiple times in a week. Another barrier was that patients themselves sometimes didn't understand the reason for their screening visits. So all of these FQHCs have diabetes education classes, but one of the things that the focus groups and in-depth interviews were able to get at was there was sort of a disconnect between what was being taught in those diabetes education classes and the patient's understanding of the reason for teleretinal screening. Many of them thought it was for visual acuity. And they're like, I don't need glasses. Why do I need to come for this? And that was unfortunate. So we saw a kind of a gap between the language used in medical education and the patient's understanding of their particular condition. Another thing is when patients felt that their eyes were fine, they didn't want to come in for teleretinal screening, because with the digital non-mediatic camera, the ideal is that you have in a room that's dark enough that a patient's pupils dilate naturally and you're able to take images of the retina. Many of these clinics didn't have a room that dark, so they would dilate the patient's pupils using eye drops. But what that meant practically for a lot of these patients who are essentially working poor was they would have to take time off of work and get a family member or friend to also take time off of work and missed wages for something they didn't perceive was a problem. They thought that there's nothing wrong with my vision. So that was another thing that we came to understand. We also found that there was a need for an image quality rating cutoff for the photographers. So many of them were amazing medical assistants, but didn't quite get the hang of the camera in spite of multiple training. We had a site where one of the lead medical assistants, it took him 6 months to be able to get images at the quality level from the Berkeley team to where he could start working on patients. So that's a long amount of time. And so one of the board certified ophthalmologists on our project, Lauren Daskovich, who I'll talk about again later, set a cutoff for image quality for future clinic use for each of the clinics. So if a target where if the medical assistant wasn't meeting that target, they should have a backup photographer and transition, because somebody could be a great medical assistant but just not get the hang of the camera. So facilitators included medical assistants who are proactive in terms of troubleshooting, and clinical environments that rewarded photographer creativity for troubleshooting. So the medical directors of the different clinics had different management styles, and places where they had to wait and run everything by the medical director before they could make any changes had a little bit more trouble with the teleretinal screening program than places where the photographers felt like, oh, here's a problem, here's how I solved it, and the medical director would actually congratulate or reward them for that. Another thing was acknowledgement of the importance of screening by clinical staff who are not involved in the study. So one of the things that we had at the beginning of the study was to talk to all the providers at the clinic to explain what the program was, so that they would not pull medical assistants off of camera duty to do other things. And sites that understood and adhered to that did a little bit better with teleretinal screening than sites where they were like, look, we're short-staffed anyway, I'm just going to have to pull the medical assistant off of camera duty. And then another facilitator was, incentives for photographers to maintain or improve upon their skills. Incentives might be a little bit of a misleading word here. So the clinics didn't have additional funds to give photographers. So what they did is with our screening program, the board certified ophthalmologists were rating the photographers across clinical sites. And that was shared across clinical sites. And photographers sort of developed a healthy rivalry to see how many could get, like the maximum quality rating across the site. So it sort of became its own incentive, like, okay, this week, who's essentially going to be at the top in terms of the image quality scale. And so that was interesting because it didn't require additional funds that the clinics didn't have for them to try to improve upon their skills. So I just showed that, the screening rate in that year was 29%. And that got me thinking, there's still a lot of people who essentially didn't get screened, but we knew the program would go on, but who even, after the program had been going on for a while, given the things that we learned from the qualitative research, there would still be people who would either not understand why this was important for them and or be otherwise uninterested in participating in teleretinal screening. One of the things, for example, that the sociologists and anthropologists on the study learned was that a lot of the patient population that were immigrants felt that anything to do with technology represented progress. So they were happy about having a teleretinal screening program. They're like, oh, there's computers and there's machines, and this is really great. A lot of the patients who were not immigrants felt they were being cheated. So this is pre-COVID. Now everybody's more used to telehealth. A lot of the patients who were not immigrants felt that they preferred to see a provider in person one-on-one. And there was a trust issue because they brought up multiple times to the interviewers that they didn't know what was going on with their images when they're not there. It's like, I don't know if the person reading it is, drunk or, I mean, it was kind of interesting the scenarios they came up with, but there was a trust factor there. So that was that was an interesting thing that we found. So back to why we did the machine learning study is essentially we knew that there was a population that potentially had retinopathy and wasn't going to come in for teleretinal screening. Like, so I started thinking, is there a way we could identify them? And so we collected data on 513 of the patients, data on risk factors that we already knew from the biomedical literature for diabetic retinopathy, and found that this was moderately, not great, but moderately predictive of diabetic retinopathy. So I'll talk about class imbalances later, but that ended up being a factor with this data. So I'm using a Bayesian network with no adjustment for any kind of class imbalance, which is the fact that you have way more people with no diabetic retinopathy than people with diabetic retinopathy. The sensitivity of the machine learning classifier Bayesian network on the data was 26%. Specificity was 94%, and AUC of 0.7. So it was very good at saying who didn't have diabetic retinopathy, but not good at picking up who had retinopathy. Then using an ensemble of weak decision tree learners, which, to try to adjust for the class imbalance, we're able to improve the sensitivity to 69%, but at a cost of major hits of specificity and an AUC of 0.72. But this sort of got me thinking about machine learning as a way to try to identify patients who are at risk for retinopathy and do outreach to them. So after our teleretinal screening study ended with the 6 FQHCs, they continued to perform teleretinal screenings for DR. They chose to use optometrists on cost grounds and convenience grounds. So they didn't retain, well, one of the sites still had an ophthalmologist, but most of the sites used optometrists for their screenings. The county on its part had rolled out a new referral process using e-consult, which made it easier for the providers at the FQHCs who are not, employed, they're working for a different organization from the county. It made it easier for them to understand what was going on with their patient in the county once they were referred, without having to wait for the patient to come back and tell them what happened with their specialist referral. And then the county, on its part, established a teleretinal diabetic retinopathy screening program that initially accepted patients from county safety net clinics, so ambulatory care clinics within the county, and eventually all FQHCs in Los Angeles. So for that initial project, the 3 board certified ophthalmologists were Lauren Pedi-Daskovich, Miguel Unzueta, and Michelle Banks. And a lot of other people had, helped to make the project as successful. So the initial work was sponsored by the NIMHD, a pilot grant, and we had a number of publications. And I'm going to talk a little bit more now. I'm going to switch gears to talk about the more recent work that we've done building on that initial pilot. So we got a National Library of Medicine funded R01 study, a multi-PI study, to look at machine learning methods to essentially detect diabetic retinopathy from data in patient records. So we knew from the pilot on 513 patients that it was possible, but it would still be challenging. And one of the major challenges is just the signal in the data. So when you're trying to predict or trying to figure out whether somebody has diabetic retinopathy from electronic health record data, you're basically looking at proxy information on hemoglobin A1C levels and so on, but you don't see the visual cues that a provider would see. So a provider looks into a retina or looks at an image of a retina and they see cotton wool spots, they see hemorrhages, they see, the proliferation of these fragile blood vessels. You don't have any of that directly recorded in the EHR, but you have proxy information that would lead you to believe, okay, this person might be more likely to have retinopathy than another person. So the Charles Drew part of the study was trying to look at EHR data to kind of figure out who isn't being, of diabetic patients who are not getting screened, who is at high risk of diabetic retinopathy, and reach out to them. And then we wanted to compare different machine learning methods and look at sensitivity, specificity, and the area under the ROC curve of different machine learning approaches. The UCLA Voxel Cloud. So Voxel Cloud is a startup of a group of UCLA PhDs actually, and doing deep learning on images, not just, so they look at, I think, brain, lung, and other images, not just retinal images. And so they're doing the kind of work that Google published in JAMA, essentially looking at retinal images and staging and grading automatically diabetic retinopathy from retinal images. So if you have the retinal images, you can see, you can basically train the models with convolutional neural networks to detect the features that indicate a particular stage of diabetic retinopathy. And there we wanted to compare the machine learning models to optometrist assessments of the same images and ophthalmologist in-person eye exams of the same patients. I'm going to talk more about the CDU part of the study, which focuses on EHR data. So this grant was a partnership with UCLA and the Los Angeles County Department of Health Services. And LACDHS, as you all probably know, is the second largest municipal healthcare system in the US, second only to New York. It caters to 750,000 unique patients a year, of which about 142,000 are completely uninsured. And 85,000 patients who had diabetes were seen between 2019 and 2020, but about 46,000 diabetic patients are empaneled to the county. So some of the patients who are seen with diabetes might come in once or twice, but they're not empaneled to the county. So Lauren Daskovich, who I mentioned in the pilot study, took some of the observations, some of the insights that we got from the pilot and used those in establishing a countywide teleretinal diabetic retinopathy screening program. So when we were doing the pilot study, she was a Robert Wood Johnson Clinical Scholar. And she made a point of visiting each of the 6 clinics to find out, to also talk to the medical assistants, to point out when they would take an image that was essentially completely black, which nobody could, you couldn't see any features, to sit down with the medical assistant and explain why an ophthalmologist wouldn't be able to read, to detect anything from that, and sort of also understand on their part the issues they had with pupil dilation and, problems for some patients taking retinal images. And so some of these insights were used for this launch of the countywide teleretinal diabetic retinopathy screening program. It has 10 optometrists and uses ophthalmologists overreads for some oversight. And the objective of that program is to screen all diabetic patients in LA County, in the LA County DHS system annually per ADA and DHS own guidelines. So after Lauren introduced the teleretinal screening program, the county-wide DHS screening rates improved from 37.7% in 2012 to 64% in 2019, which is pretty good. So this shows the team. The PIs are myself and Ricky Tyra at UCLA, and Lauren is the sub-award PI for this grant. So I'll talk a little bit, I alluded to this, but I'll talk a little bit about class imbalance in machine learning. And this is where, the class that we're trying to predict is underrepresented in the data set that we're learning from. And that's not uncommon, but this sometimes also occurs with an overlap in the classes we're trying to separate. So it can be difficult. It's challenging to separate the classes. And standard machine learning classifiers have a bias towards the class that has a greater number of instances in the data. They have a bias towards the majority class. And this is a common problem with prediction in medicine. Most places see far more patients who don't have a particular disease or condition than patients who have it. So a class imbalance is not necessarily a problem in and of itself, except when you have a difficulty in separating the classes. So if you had a data set with people who have very obvious, so if you, for example, with an imaging data set, you have 1,000 cases where people don't have diabetic retinopathy, but you have 80 where you can see there's these fragile blood vessels growing that you don't see in other images. The class imbalance is not an issue because you have enough signal, you have enough data to still do good prediction, even with a small number of cases. So with the diabetic retinopathy EHR data, the class imbalance becomes more of a challenge. And so just going on with the information on class imbalances, so just using a 2x2 table where you have 1,000 patients and 900 of those patients don't have a disease you're interested in, 100 do. And you have a machine learning classifier and you have essentially 900 negative training examples, 100 positive training examples. But what you're trying to do is predict who has the disease. And so this is obviously an example of a class imbalance, but the problem here is that a standard classifier can get high accuracy by simply predicting that no one has the disease. And so the accuracy of this classifier, which essentially says all 1,000 patients don't have the disease, accuracy is 90%, but it has 0% sensitivity because it's not able to pick up anybody who has the disease, and 100% specificity. So here we have a classifier that's essentially useless at detecting disease, but it's excellent at telling us who doesn't have disease. So in the computer science world, many times accuracy is used as a metric because you have a balance in the classes that you're looking at. And in biomedicine, it's not always as useful. And so AUCs end up being a better metric. So there are multiple approaches to handling class imbalance in the literature. Some include modifying the learning algorithm for the classifier to penalize misclassification of the minority class. So the class that you're trying to identify, the disease state you're trying to pick up, modify the learning algorithm to penalize misclassification there. There's also data pre-processing approaches that essentially try to rebalance the distribution of the data. Majority class undersampling, where you drop some of the randomly drop the extra case instances of the majority class, and then minority class oversampling where you boost. And obviously each of these has its own pros and cons. With majority class undersampling, you're actually kind of losing a lot of potentially useful information. There's also cost-sensitive approaches that combine algorithm modification and data pre-processing strategies. And then there's the use of ensembles of different types of classifiers that have combined the strengths of different individual classifiers to overcome the problem with the class imbalance. So as a reminder from the earlier pilot study results that I mentioned, on the 513 patients, when we didn't have any adjustment for a class imbalance, we had really low sensitivity, really great specificity. But when we did, we had decent sensitivity, but specificity took a real hit. So we wanted to see if we could do better. So the data source for this was the Los Angeles County Department of Health Services Cerner EHR system. And this is where I have to thank Daniela and her team. So a lot of the data that we ended up pulling for this study came from through USC's CTSI, from the Cerner system, from the data warehouses established for that. So we pulled variables that corresponded to known diabetic retinopathy risk factors from the biomedical literature, but also variables suggested by the endocrinologists, ophthalmologists, and so on our study that could address micro and macrovascular complications of diabetes, which would also hopefully explain progression to potential vision loss. So we were able to get data on 40,631 patients seen between January 1, 2015 and December 31, 2017. And this included both type 1 and type 2 diabetic patients seen in the county DHS system. So 31% of the records indicated that the patient had DR, and the majority, 68.9%, didn't have DR. So we did have a class imbalance. And so that was the data for the training and test set. We also established an external validation set. So ideally, we would want external validation set from a different facility. But in this case, what we did was get records for patients seen between January 1, 2018 and December 31, 2018, who had not been seen in the period that we got the training and test set from. So there's no overlap between the patients in the external validation set and the patients in the training and test set. And we were able to get data, again, with the help of Daniela's team, on 9,300 patients. And we initially looked at socio-demographic variables, age, sex, race, marital status, ethnicity, general health overview information, clinical measurements, comorbid conditions. I won't get into that so much in this talk, but there was also the challenge of, there was a challenge of data quality itself. So a lot of the work on the project was data cleaning and processing, in the data cleaning and processing stage. And so some of what I'm going to present next is in a JMIA open paper, detecting diabetic retinopathy through machine learning on EHR record data from an urban safety net healthcare system. So we looked at this total number of variables, and we did some feature subset selection to reduce the number of variables that we would look at. But we picked a number of classification methods to assess random forest, support vector machines, extreme gradient boosting, and then an ensemble of classifiers that included random forests, gradient boosting machines, and artificial neural networks. We also did deep learning with a deep neural net, and then decided to apply data preprocessing methods to address the class imbalance. So we tried both majority class undersampling and minority class undersampling using the smoke technique. We ended up having to drop variables that had over 35% missing data. And when we performed feature subset selection to find the most useful feature subset for prediction here, we came up with 14 variables: age, sex, kidney disease, nephropathy, neuropathy, hemoglobin, insulin dependence, blood urea nitrogen, blood pressure, how long a person had had diabetes, their ethnicity, their hemoglobin A1C levels, whether or not they'd had a stroke, and their triglyceride levels. So we performed our analyses using both R and Python, and handled missing data with k-nearest neighbor imputation. We actually used a lot of different methods, but this was the one that gave us the best result. We reserved a random selection of 34% of the data set as a holdout test set, and performed 10-fold cross-validation of the remaining 66% of the data. And then we looked at the best models from cross-validation on the test set and on the external validation set. And so this gives some of those results. And this is also included in that that JMIA open paper that I previously mentioned. So we found that when we did minority class oversampling, the ensemble of different classifiers had the best AUC results. with a sensitivity of almost 64% and a specificity of almost 80%. Also did better on the external validation set, the ensemble model, with a sensitivity of 60% and a specificity of 82%. And we wanted, obviously, the external validation set to see how well the model generalized to a previously unseen population. Looking at majority class undersampling, we ended up seeing better results overall, slightly better results overall. And here the deep learning with a deep neural network ended up producing the best areas under the ROC curve for the test set, 0.806, and a sensitivity of 73.5%, specificity of 72.7%. And on the external validation set, the deep neural network also did better with the sensitivity of 72% and the specificity of 74%. We built a web-based tool called DRRisk based on the deep neural network model. And it basically allows input of the 14 variables. In talking to providers, though, they still felt that 14 would be a lot to ask. So the model allows a user to input as few as 6. So there's 6 mandatory variables that have to be input. And when fewer than 14 are input, the rest are inferred, but it's not ideal because you're basically performing imputation based on the training set data. So that's not ideal, but that's how we were able to bridge this, the gap between what providers are willing and able to do and what the model would need. So DRRisk provides an output of whether a patient has low, moderate, or high risk of diabetic retinopathy based on the values input. So the next phase of our work was study outreach. And in the original grant, obviously, we did not plan for a pandemic. So as I mentioned, Lauren had gotten the screening rate in the county from about 32% to 64% between 2012 and 2019. And so we had thought we would be reaching out to a small number, I mean, not small, but, maybe 10,000 people who had missed an annual exam. But because of pauses due to COVID-19, we found that over 31,000 people had missed an annual exam. So our study, we followed our protocol. We reached out to 31,000 people, sent reminder mailers to them, robocalls and text messages if the patient's appointment had not been scheduled within 2 to 4 weeks of receiving the mailer. And then we had machine learning supported targeted outreach. So we applied the models to the data on the 31,000 patients, and 7,500 were identified as high risk for diabetic retinopathy by the machine learning methods. And so we removed county patients who had opted out of phone contact or had no phone. So we had about 7,494 patients left. Almost 5,000 of them were primarily Spanish speaking. And so we had our bilingual health educators and research assistant make calls to the patients. And this ended in September 29 of 2021 when the grant ended. So we were able to reach 2,165 of the patients. 32 of them were deceased, 23 refused care. I'll come back to that. 185 went on to receive or had received eye exams through DHS by the time that they were called. 30 had received eye exams outside of DHS. 148 were scheduled for an eye exam. 4 had already experienced vision loss. And 354 messages were sent to primary care providers regarding scheduling the patients who wanted to be seen for teleretinal screening. So of those who refused care, it was really interesting. There was a particular case that stuck out in my mind when we were having our weekly discussions. an elderly woman who lived with her daughter and was pretty much having most of her needs met at home, and didn't want to go for teleretinal screening because she felt that the clinics were where she would catch COVID. So she was willing, she understood the risks, but was willing to take that risk because she didn't want to go to the clinic where she might catch COVID. So that was an interesting finding that we hadn't expected. So I'll just say that the work, this work was funded by the National Library of Medicine, the machine learning work. And thank you so much for attending. And I'm happy to take any questions that you may have.
I've got a question. Yeah, thank you. It was a wonderful talk. My question is comparing the deep learning to just sort of sophisticated recent data analysts not using deep learning tools. What do you think would happen? In other words, would the AUC curves be considerably low because of the humans in patients ensuring for that data? What do you think?
So I'm really sorry. I think you were asking a question about the deep learning and the AUCs, but I couldn't make out.
Yeah, I'll come closer to the mic.
Okay.
Is this better?
Yes, please.
Yeah, okay. My question is, how would you compare the deep learning algorithms to just having a very skilled, user of proclogistic and stats, for example?
Oh yeah, so we tried logistic regression, and it didn't do as well as any of the methods that I presented, the support vector machines or the, yeah.
Just to follow up on that, because I guess I'm a little surprised to hear that, because in your results, all of the AUCs were fairly close.
Pretty similar, but if you look at the sensitivities and specificities, that's where from the provider perspective, they're more interested in higher sensitivity for this particular problem. But given that we're looking at 14 variables, it's not that,
Yeah, so it's not so much, using these techniques to do feature selection. It's more choosing the appropriate weights among the 14 to really balance out the cost and benefits given some loss that you applied with the particular machine. Okay, now that makes sense. Okay.
Yeah. And so one of the things that we're looking at for the future, because now we're limited to these 14 variables, but we want to take advantage of other data in the record. So Daniela, this is coming down the pike. We want to basically, one of the things that we realized with the data, for example, is that duration of diabetes is really important. But the way the county handles this, and this is similar across different healthcare settings, is they test the patient and say, okay, now we're sure you have diabetes. But the patient may have been told they had diabetes somewhere else earlier. That's usually in the physician notes. So we're also looking at deep learning to try to figure out, to better, more accurately capture what the duration of diabetes is from using natural language processing on the patient notes, and not just the standard value that we're given, because we know that the data we have on that is not the most accurate data. It's when the county said they had diabetes, but we know that's for not necessarily the real date of diabetes onset from many of these patients. We also want to see whether we're able to pick up things in the notes, in the clinical notes, using NLP that might indicate progression the way that the imaging features would. So not just so right now, the study I presented is basically static machine learning on, the fixed sort of variable set. There's no free text, there's nothing, but we think we could do better. And so that's one of the areas that we're looking into. And also to look at, so again, I just mentioned that they're static. So if somebody, when we looked at people from between 2015 and 2017, if we're looking at the hemoglobin A1C values, those are averaged across that period of time. With recurrent neural networks and other models, we can look at trends. We can say, okay, their average AUC might be 8, but we can see that in the last year, it's been trending upwards to 13. And that tells me more than an average value over 5 years. Or in the last year, it's been trending down towards 7. That tells me maybe this person is not as much at risk. So doing those kinds of things, anyway, those are some of the things that we're looking at for the future.
So Lola,
Oh, go ahead, Danielle.
I just one quick clarifying question towards that point. You mentioned that some of the progression is reversible.
Yes.
Are you able to detect a healed retina and the difference between a healed retina and one that is having the very first incidence of this? In other words, does that progression go backwards and forwards, and could you detect that?
So unfortunately, one of the things that I noted, unfortunately, in the safety net setting, they rarely see someone get their diabetes so well managed that they have a reversal. So I talked to several providers and they couldn't think of even one case. So yes, it's technically possible. It very rarely occurs. The more challenging thing in this setting is actually those who've had laser photocoagulation therapy, because they're considered as having quiescent diabetic retinopathy. So they're already lasered. But if they're only lasered in one eye, well, things could still be going on in the other one. If they're lasered in both, this is where I would need more clinician input. Can it come back? Like, are they still at risk, or is it just considered, problem solved? You can never have that proliferation again. That part I don't understand. So I would need to talk with the clinicians a little bit more, because that changes how you approach things.
Thanks for a nice talk. At the end, I think you were talking about the situation where you don't have all 14 variables available.
Right.
And if I understand right, you use the data you have to impute.
Yes, and it's not ideal. We know that.
I was wondering whether, as an alternative, you considered just rebuilding your machine learning models on the subset of variables. And a related question is, do you know what
we could.
Sensitivity and specificity look like for those models where you have to impute? It's obviously not going to be as high.
It's not going to be as good. Yeah. We already know that. But you're right. We could basically build models on various subsets and look at that instead of imputing.
Oh, it would avoid the need to impute, which has probably its own issues involved. Right. Anyway, okay, thanks.
Thank you.
Wonderful. Any further questions? I know we're a little bit over time here, so I'll ask everybody to thank the speaker one more time. Thank you, Lola. That was wonderful. And while people are heading out or not, I have one more question. If people in this field are thinking of using polygenic risk scores to supplement these models on clinical data, because I know there's some work out there, certainly in type 2 diabetes, there's some well-established prediction, but then conditional, and if they have diabetes, can they predict using genetics for that? And would that supplement the model and help with?
There's I think his name is Jerome Rotter. There's like a whole group that has looked at VEGF and other factors. The thing is, I don't know in the count. Daniela, you may be able to answer this better. I don't know how much genetic testing is being done in the county at all. I don't know how much of that kind of data they have, because it just doesn't seem to be a setting that lends itself to a lot of that. But I might be wrong.
Yeah, absolutely. It's not going to be something that's available in any general hospital system as of now, but maybe thinking as a way.
Yeah, no, in the future. Yeah, and Jerome Rotter's work has already shown there are some things. I think they were looking at Latino patients mostly, but there were already things that they were able to pick up that show a predisposition to diabetic retinopathy in those populations. Yeah.
Excellent. Thank you so much. That was a wonderful talk.
Thank you.